Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave. Hello, everybody. Welcome to The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. You can learn more about me and get connected at www.drshanibelgrave.com. I am delighted and grateful to welcome to the show today esteemed breast surgical oncologist, Dr. Yara Robertson. Dr. Yara Robertson is the chair of surgery at the Carti Cancer Center in Little Rock, Arkansas. She joins the show today to let us know what we should know about breast cancer, right on time for Breast Cancer Awareness Month. Dr. Robertson, thanks so much for joining the coalition.
Oh, thank you. Appreciate being here.
Awesome. So can you please start us off by telling us a little bit about who you are and what you do?
Sure. My name is Dr. Yara Robertson. I am a breast surgical oncologist here in Little Rock, Arkansas at Carti Cancer Center. I'm originally from Memphis, Tennessee. I did my undergrad in Chattanooga, did my medical school at East Tennessee State University, and I matched into general surgery. And I also did my fellowship at the University of Arkansas for Medical Sciences. When I finished my fellowship in 2011, I was recruited to a private practice breast oncology practice in Atlanta, Georgia, where I practiced for almost nine years, almost 9.5 years. I was recruited back to Arkansas to join another breast surgeon at Carti Cancer Center, which is not with the university, but a large cancer center that stands on its own. In 2022, I believe, maybe 2023, I was promoted to medical director of surgical oncology, where I have been in that role for quite some time, and I love it.
Amazing. Again, thank you for being here. So what can you tell us about the magnitude of breast cancer and the scope of this issue?
So, talk about breast cancer affecting 1 in 8 women, or 13% of women over their lifetime will be affected by breast cancer. So in 2024, over 310,000 women will be diagnosed with breast cancer, and 2,800 men, and over 42,000 women will die of breast cancer. Now, when you look at those statistics, we have to remember more and more women are surviving breast cancer, and men as well. And that's because we have earlier detection and better treatment options for women and men. One of the issues that we face is that Hispanic women, even though they're diagnosed, they're the least likely to be diagnosed, they still have a 20% mortality rate. And Black women, even though we are less likely to be diagnosed with breast cancer than our white counterparts, we have a 40% mortality rate as well. That's a big disparity that occurs. It's multifactorial. A lot of it is because of some of our genetics, because of our medical history. We're not as healthy as time, we're more obese, but then also some of it is a bias by providers, later diagnosis. Sometimes we get blown off, medical distrust. So there's a lot of stuff that goes into that. So there is still a disparity that exists for Black women and Hispanic women, even though our breast cancer detection rates are better and our treatment is better. Not everybody's getting the same care.
Wow, that is amazing work that you're doing. So, as you were speaking about this, what are some of the risk factors for breast cancer?
So there are some risk factors that are not modifiable. And what I mean by that, the 2 most common risk factors for breast cancer is number 1, just being a female, and number 2, getting older. Those are things that we really can't change. We really can't change our family history. Other things that we look at is when you started your menstrual cycle. Those that started earlier are more likely to be diagnosed with breast cancer. Women who haven't gone through menopause, if you haven't gone through menopause until late in life. Also, we look at people who are breastfeeding, but all those risk factors sometimes don't point to the fact that you'll develop breast cancer. Another thing is if you have a family history of breast, ovarian cancer, or if you yourself have been diagnosed with the cancer in the past, like breast cancer, you're at higher risk. There's some high risk. I'm going to rattle it off, but you don't have to remember it. There's something called lobular carcinoma in situ, something called atypical ductal hyperplasia. These things can increase your risk for breast cancer, and those women are followed a little bit differently so that we can pick up breast cancer earlier in them. There are some modifiable risk factors, like making sure you maintain a healthy weight, that you exercise, that you eat right, that you minimize your alcohol intake. They're avoiding hormonal replacement therapy if you can. For some women who are high risk, we actually tell them not to take hormone replacement therapy. So there are different things that we can do to modify our risk. There is no prevention of breast cancer, but there is a way to reduce your risk from developing it.
I'm happy you mentioned hormone replacement therapy because we had just done an episode on menopause and perimenopause. So, from your perspective, do you think that that increases the risk for breast cancer, or do you think that it's safe for a short amount of time? Like, what are your thoughts on that?
It depends upon the patient. For instance, my risk for breast cancer without having any type of abnormal genetic mutation is 43% because of my family history. I'm able to have prophylactic mastectomies right now. In a woman like me, I would not recommend they do hormone replacement therapy because we just don't have enough information. It depending upon your risk factor, it's safe, and depending upon your risk factor, sometimes it's not safe. So I'm a proponent that you can use hormone replacement therapy for a short course in the right patient. Some of our breast cancer patients who have breast cancers that respond to hormones, occasionally we have to do it because of quality of life issues. But as a whole, for those women who have hormone positive breast cancers, we really don't like giving them hormone replacement therapy. So in the right patient, it is fine for a short course. Another thing is, one of my pet peeves is finding a 77-year-old woman who has been diagnosed with breast cancer still on hormone replacement therapy. We have to know when to end it.
Good point. So, can you please share your expertise on screening recommendations?
Okay, so we have multiple organizations telling women multiple things, and unfortunately, physicians are confused as well. The American Society of Breast Surgeons, as well as the American College of Radiology, still recommend that women get their screening mammograms once a year, starting at age 40. These are average risk women. And what I mean by that, if you have a family history of breast cancer or ovarian cancer and been told you are high risk, you likely need to have your imaging more often. And what I mean by that, we start earlier. A woman who has been diagnosed with breast cancer, let's say your mom was diagnosed at age 50, we usually start screening 10 years earlier than the first degree relative. We don't recommend you skip your mammograms. There are some organizations that tell women to get a mammogram every other year. What I want to caution about that is interval breast cancers can develop within a year. And for African American women, we weren't included in a lot of those studies. So those guidelines don't apply to us. We get breast cancer again earlier than our white counterparts. So I see a lot of young Black women with breast cancer. So imagine if we tell a woman not to get her mammogram until age 50, that's 10 years of mammograms that are missed. So every year, starting at age 40 for average risk woman. And then if you are high risk, you may want to talk to your provider about biannual screening. And what I mean by that, a mammogram in the next 6 months, if you're high risk, we do an MRI or we do whole breast ultrasound. So those are two things that you have to remember. So talk to your provider about your risk. There is no age limit to mammograms. My grandmother was diagnosed with breast cancer at age 85. She had a full life. She was very vibrant at the time. Her doctor told her she was too old to be treated. She fired him. She got a new doctor and got treated, and she lived to be 97. In fact, the doctor died well before she did, and she did not die of breast cancer. So as long as you are able-bodied, if you are, we call a walkie-talkie, and you want to get your mammogram until you're just not able to be treated for breast cancer if you get diagnosed. We have several women that are diagnosed in their 80s, and they do just fine. There is no magic number to stopping your mammogram. So this age 75, I don't know what happens at 75. My mom is 77, is vibrant. So I don't know if you just drop dead at 75. There is no reason for you to stop getting your mammograms if you are healthy. So again, annual mammograms starting at age 40. And also, if you have a provider, ask your provider to examine your breast. We tell women, check your breast yourself. We're not saying you have to do a monthly breast exam like the books tell you. But you need to practice breast self-awareness. What that means is know what is normal for you, but how your breasts normally look and feel. Yes, we want you to do it at the same time every month if you can, but I don't like women getting stressed out about their breast exams. You just need to look at your breasts, feel your breasts, and make sure you know what's normal for you because you know your breasts better than anybody else. And if something feels off, go to your provider and get checked out.
Wow, that is really wonderful insight, especially about not disqualifying people for routine care based on the fact that they're aging.
And again, breast cancer is more common in women older than age 50. I see a lot of older ladies with breast cancer, and you'd be surprised at how many had not had a breast exam where they have an obvious breast mass or breast cancer, and how many have not been getting their annual mammogram.
Wow. So, can you please give us some education on some of the treatment options?
So what I tell my patients, no one wants to be diagnosed with breast cancer. But in the year 2024, we have more treatment options for breast cancer than ever before. What I mean by that is, let's say you get diagnosed with early stage breast cancer. One of the myths is that you have to remove your breast. If you have a small cancer that is localized, meaning it is not all throughout the breast, you can conserve your breast or do we call breast conservation or lumpectomy, where I just go in and take the cancer out and leave normal tissue. And then we add radiation. We used to do radiation over 6 weeks, and in some cases we still do with patients who have more advanced cancers. But what we realize, it is very safe in certain women to do a shorter course, and we can even get radiation down to 5 days or 5 treatments. Or in some places, especially like Atlanta before I left, you can do a 1-day course of radiation in certain patients. We don't offer that in the state of Arkansas, but at Emory Midtown, I know they do 1-day courses of radiation. Another thing is that if you get your breast removed or you have to remove your breast, you're offered reconstruction for the right candidate at the same time, meaning after I remove the breast, we have the plastic surgeon recreate a breast for you. We even have mastectomies now that we did the first in the state of Arkansas, where we actually preserve the nerves, a nerve sparing mastectomy. Because often after we remove the breast and we do reconstruction, although it looks very nice, you don't have the same sensation. So changes in the way we do surgery are it's rapidly changing. Another thing is not everybody needs chemotherapy. We used to give everybody chemotherapy, and we realized a lot of women did not need it. It was being overtreated. So now we have very exact ways to figure out for a woman who is hormone positive, how to determine her risk for developing, her risk for recurrence. So instead of us giving you chemotherapy just because you have breast cancer, we individualize it. And that is what breast cancer treatment is about, being individualized. We even now can do some genetic testing to see if you have an increased risk for breast cancer and offer prophylactic mastectomies. And also, there's another thing, we do immunotherapy. So when we do chemotherapy, sometimes we add medications that will stimulate your immune system to fight breast cancer. So there are so many treatment options out there. So when women get diagnosed with breast cancer, I tell them, please, please, please listen to all your options so that you can understand how to be treated. Even our stage 4 breast cancers, we have been able to, in a lot of cases, turn their cancer into a chronic condition, meaning they don't die from it. Now, yes, they are always be stage 4, but we have medicines now that can prolong their life and they can have a quality of life. But if you don't get treated and you don't get to the provider, you will never know that. So even my patients that come in with stage 4 cancer, like bone only, I've done surgery on them because a year or two later, after we've kept them on medications, we have no evidence of disease. Breast cancer does not necessarily have to be a death sentence.
Wow, this is all really useful information. And it sounds like there's been a lot of advances and changes, even from when I did general surgery residency. So
breast cancer is always changing. That's one of the reasons why I went into it. When I was a resident, I was actually going to go into vascular surgery. I love blood vessels. I love blood vessels. And they made us do a rotation on breast. Where it was the first time they did a 2-month rotation for the 3rd-year residents, and everybody was angry we had to do breast cancer care. Ugh. However, when we got on those rotations, we realized it wasn't just you take the breast off. Every patient was individualized, and that was in 2008. Things have changed so rapidly since then. We used to take everybody's lymph nodes out. Now we do limited surgery. Everybody got certain types of surgery. We try to do limit the amount of surgery we have to do on a patient. That was never heard of back then. So it changes so rapidly, and that's one of the things that attracted me to this field, is because you have to stay up on it, because at the end of the day, in order to be a good breast surgeon, you have to give your patients the most up-to-date care.
absolutely. Well, it is very exciting to have an expert of your caliber on the coalition. Is there a particular takeaway about breast cancer that you would want to leave with viewers?
Yeah, just to stress that it's not necessarily a death sentence. If you're getting your screening exams, we can't pick up every breast cancer. Sometimes we do miss things, but doing an annual mammogram, getting your breast exams, we're able to pick up a lot. So people need to get their mammograms. They need to see their provider if they feel something abnormal in their breast. Know what their breasts normally look and feel like. And if they find something, go get checked out. I'm so on the soapbox of don't let fear keep you from getting treated. If you get treated, if we find your breast cancer early, you have so many more treatment options and the world is open to you. I mean, your survival rate approaches above 90 to 95%. But the problem is a lot of people let fear keep them from getting treated. And so we find breast cancers at a later stage. Also, you can get a second opinion if you don't have a good relationship with your provider or you just have more questions. Anybody being diagnosed with breast cancer is owed that. So if you want a second opinion, go get it. And the last thing is make sure that you get all of your friends and family screened. If you're diagnosed with breast cancer, be an advocate. Make sure your family is getting their mammograms and getting checked out as well. And don't keep it a secret. In the Black community especially, we are so secretive about being diagnosed with cancer. They whisper it. Just because you have it, you didn't claim it. Just because you say the word, we want you to get treated. So be open and honest with your family and friends about it. And you never know if you can save their life.
Absolutely. There's such powerful impact with conversation and sharing information. For people watching that would like to get connected with you, what is the best way for people to reach out to you?
So I have an Instagram page at Dr. Yara Robertson, and my name is spelled Yara Robertson, Robertson. It is completely open. There's not a whole lot about me, but a lot about breast cancer care and also renal cell because I am a renal cell survivor. So I talk about that a lot. We do have a TikTok with my radiology colleague named Dr. Stacy Smith Foley. It is called Breast Friends for the number 4 ever EVA.
I love that play on words.
So we do dance on there and we give a lot of breast health tips. And in October, we are very active. Of course, we're active all year round, but in October, we're very active because that's the time of the year that everybody wants to hear about breast cancer.
Absolutely. Well, I learned a lot during this episode, Dr. Robertson. I want to thank you again. You have an open invitation to come back to the coalition anytime. I hope
thank you.
Up on it. Thanks so much. Well, everybody, thanks so much for tuning in to another impactful episode of the Coalition. Very special thank you to Dr. Yara Robertson, breast surgical oncologist. You can learn more about me at www.drshanibelgrave.com. Feel free to connect with Dr. Yara Robertson on Instagram. Thanks, everybody, for watching. I'll see y'all next time. Make sure you share this episode with family and friends so that we can raise breast cancer awareness.